All right. Welcome, everyone. It's 12 noon, and we'll go ahead and get started with this edition of Medicine Grand Rounds. This Medicine Grand Rounds is our annual Wade Volwiler Lecture, an endowed lectureship from the Division of Gastroenterology. And to introduce Wade Volwiler Lecture and introduce our speaker, Dr. Neena Abraham, I'm going to turn the podium over to Dr. Rotanya Carr, who's the head of the Division of Gastroenterology. Rotanya?
Thanks, Conrad. It is my pleasure to introduce to you Dr. Neena Abraham, who's a wonderful colleague and really just such an inspirational leader in the field of GI and beyond. This lecture, for those who are unfamiliar with this name lecture, is named after the person who started our division, Dr. Wade Volwiler, and the original division head. And our division is 75 years old this year, and we're very excited to be honoring our 75th year with Dr. Neena Abraham's lecture today. Dr. Abraham is a professor of medicine at the Mayo Clinic and a consultant in the Division of GI and Hepatology and Healthcare Policy Research. She completed her medical school training at Dalhousie University in Halifax, Nova Scotia, Canada, her residency at the University of Alberta, and her GI fellowship and advanced therapeutic endoscopy fellowship, as well as her postdoctoral research training and epidemiology degree at McGill University. She's currently the medical director of the Mayo Clinic Cardio-Gastroenterology Clinic, so you will learn what that is today. She is the only one in the world who leads such a program, and we are really just so happy and honored to have her lead this field, because it is one of the most common reasons we are seeing patients with GI bleed, because they are on antithrombotic agents. So she is the expert in the management of these patients. Her clinic is a multi-specialty collaborative care model and really aimed to improve the clinical outcomes of these patients who are GI bleeding. She's also a funded investigator, with her work being in outcomes as well as in health services research at the intersection of cardiology and GI disorders. She is a primary author of probably all of our consensus and guideline documents on this topic, with the most recent being the 2022 guidance by the ACG talking about the management of anticoagulants and antiplatelets during acute GI bleeding in the peri-endoscopic period. She's authored a number of other guidelines and consensus documents, as well as many manuscripts. She's the first female director of the American College of Gastroenterology Institute for Clinical Research and Education, and a member of the ACG's Board of Trustees and ACG Board of Trustees executive team. Under her leadership, this institute has raised more than $2.2 million to fund research, and this is record funding and donations under her leadership. In 2021, she launched the ACG Institute Center for Leadership Ethics and Equity. And this institute really works to train the next generation of leaders in GI. And one of its goals is to reduce healthcare disparities and advance health equity. Dr. Abraham has served in leadership positions of all of our national GI societies in the US, as well as in Canada. And in 2021, she was recognized as Helios and ACG's disruptive innovator in clinical medicine. And just a couple of years ago, she was also named one of 108 Masters of the American College of Gastroenterology for her contributions to GI leadership, education, and science in the United States, one of only 8 women to have done so. So welcome, Dr. Abraham. We look forward to your talk.
Thank you again, Rotanya, and the faculty here at the University of Washington. This is my 3rd visit here to UW over the last 28 years, and I'm so honored to be the visiting professor named in honor of your founding faculty member. It's a tremendous honor, so thank you. Today, what I'd like to talk about is really my clinical passion, which is GI bleeding and how to prevent it in patients who are prescribed antiplatelets and anticoagulants. And I'm going to do so from the perspective of someone who has written a tremendous amount of clinical guidance on the topic, because I think it is important for any internist to understand where this guidance comes from and how we create it and what the implications are for our clinical practice. So first of all, let's frame this question by answering, am I seeing more GI bleeds in patients on antiplatelets and anticoagulants? Well, indeed you are. By 2040, it is estimated that 60% of the US adult population will be prescribed at least one antiplatelet or anticoagulant, and many of them will be on more than one of these agents for cardiovascular disease. And this is a population that I started studying over 25 years ago, aging baby boomers. And as they have aged and developed their cardiac disease, we have seen a huge difference in the epidemiology of GI bleeding. So I shared this slide with you just to demonstrate what this looks like. And what you see here in these bars is the same pattern repeated over and over and over, regardless of the reason, the indication, cardiac condition for which these drugs are prescribed. GI bleeding increases based on two factors: age and the number of antithrombotic drugs that are prescribed. To put this in concrete terms, if you are under the age of 65 and on an antiplatelet or anticoagulant monotherapy, you can anticipate having a 4% annual risk of GI bleeding related to these drugs. Once you hit the age of 75, that annual risk goes to 10%. And then if you are prescribed more than one agent, that 10% risk over the age of 75 goes to 17% per year. So it's no small problem. And it is indeed the number one reason why gastroenterologists are coming in the middle of the night to treat GI bleeds. So clearly, this is a patient population where guidance is needed with regard to how to manage their drugs, both in the acute as well as in the elective setting. The other reason why this group is particularly important is we have now come to recognize that GI bleeding in cardiac patients is more than a nuisance side effect. It actually has a big impact on mortality of the patient. In a patient who is newly prescribed an antiplatelet or an anticoagulant, 6.5% of them will die within 6 months of their first GI bleed. That number goes to almost 9% within 1 year of incident GI bleed. So the prevention of GI bleeding and the appropriate management of GI bleeding becomes incredibly important as a proactive strategy to reduce mortality in this population. So at the end of today's session, I want to leave you with 3 concrete teachable points. Number one, I want to share with you a little bit about how we establish best practice and focus on the why, the who, and the what. I'm also going to share with you the new paradigms that we published in the 2022 American College of Gastroenterology, Canadian Association of Gastroenterology, Multidisciplinary Clinical Practice Guideline, which addresses the management of antithrombotic drugs in both the acute and the elective setting. And finally, I always like to leave the audience with some actionable tips from the Mayo Cardio GI Clinic, because I appreciate that this has been our singular focus for a very long time. And so we have got a lot of practical experience on how to operationalize these gaps, these guidelines in our patient population. And we've also got great experience with the gaps and the limitations. So let's talk about establishing best clinical practice. Why is that necessary? Well, It's estimated that for all of our clinical decisions, about 60% of them can be based on evidence, but 40% of them are based on experience. And when we are in the situation where we don't have good evidence or weak evidence to guide our decisions, we often will turn to our national guidelines and best practice documentations to tell us what is the best current practice for addressing that clinical question. Now, what I've learned from working on these documents for a variety of organizations, as you see on this slide, is that there is a different level of rigor that goes into each type of clinical practice document. And I don't think a lot of practicing physicians understand that they're not all created equal. So a clinical practice guideline is usually, or should be, if done correctly, the most robust evidence-based document. Then after that would become a consensus statement, followed by a white paper, an international expert panel or Delphi panel, and then finally a care pathway. So in descending order of rigor. It's not just the rigor that is different between all of these documents, it's also the degree to which expert opinion appears in the best practice recommendations. And at the end of the day, to be an informed consumer of these best practice recommendations, you as the physician have to be able to distinguish documents' opinion versus evidence. I always like to tell people that after having written 9 of these documents, if you were to pull back the curtain on the process, it's a bit like making sausages. You like the end product, but you really don't want to know what goes into it. And what we spend a tremendous amount of time on around the table, especially if we're doing a clinical practice guideline, which is the most rigorous, is ensuring that we are continuously distinguishing opinion from evidence. And that's because facts, actual facts that support our conclusion are very different from the operationalization or views or judgments formed about those facts from people who are supposed to be experts in the field. And that is not done to an equal extent in all of those documents. So one of the things I hear my GI fellows say is the most recent guideline on X, Y, or Z says something. And I always challenge them by saying, are you sure that's a guideline? Why do you think it's a guideline? Just because they called it a guideline, is this mostly made up of evidence, or is this made up of facts, or is this a bit of both? So this is the guideline I'm referring to, which was our most recent multidisciplinary international guideline. And what was special about this was actually 3 things. First of all, the American College of Gastroenterology partnered with the Canadian Association of Gastroenterology, who takes great pride in their guideline creation. And they follow a very rigorous grade process based out of McMaster University. Secondly, we wanted this guideline to be multidisciplinary and reflect the perspectives of not only gastroenterologists, but also world-class cardiologists in this area and hematologists. And finally, we wanted to make sure that this guideline addressed the common clinical questions regarding management of these drugs, given the rapid emergence of new drugs, such as the direct oral anticoagulants that had been available for use since 2010. Now, our guideline was very rigorously done. We followed a grade methodology, and to give you an example of the rigor, we have over 500 pages of evidence to decision tables and data that the journals published online to accompany this guideline. And our guideline was focused on answering 4 important clinical questions: the temporary interruption of anticoagulant and anticoagulant drugs, questions around reversal, heparin bridging, and drug resumption. Now, you'll notice that there are 2 guidelines that were published in this April edition of the Red Journal. There's the actual guideline document, which is the first one. And then there's another accompanying piece, which is called a dissemination tool. And that's because in a true grade methodologically done guideline, the actual interpretation of how you should operationalize the guideline in clinical practice should not appear. And so that is why there is an accompanying dissemination tool in our journal to help clinicians take the academic content of the grade guideline and use it in clinical practice. So I always want to tell people who are interested in this topic to be sure to read both. If you're short on time, read the dissemination tool and use the guideline as the definitive resource for the academic discussion. So what exactly is the grade approach? Well, the grade approach comes out of McMaster University, and it is a formalized method of grading recommendations, assessment, development, and evaluations. And that grade process has been shown to be invaluable in helping create formalized structures to prevent bias or limit the amount of bias and opinion in the best practice recommendations that are published. Now, you will see in all national clinical practice documents some reference to grade. Very few actually do not reference grade, but how they operationalize it is very different. And having worked with a variety of organizations in the United States, I can tell you that not all of them are done with proper grade. I like to call some of them grade light, grade like, or grade-ish. For the purposes of this 2022 guideline, we wanted to come as close as possible to true grade methodology because we had the benefit of working with the Canadians, and our methodologists were all from McMaster. So what is it that you need to know as a clinician about grade, and how is that different from other guideline documents that you may be seeing? Well, in a proper grade process, the clinical questions are framed a priori using a very standardized definition of population, intervention, comparator, and outcome. A systematic literature search is then conducted independently to answer the clinical questions that you've decided you're going to address. Most guidelines and documents in the United States, not just in GI, but for most societies, are actually driven by a search of convenience. We want to write a guideline on topic X, so let's see what's in the literature. Once you have that literature, you then frame your questions. But in the grade approach, that's a bit like putting the cart before the horse instead of the horse in front of the cart. And it does inherently introduce bias in the final recommendations. The other thing that grade does that's really important is it spends a lot of time quantifying the risk of bias of studies, and they call that the certainty of the evidence, which can be very low, moderate, or high, and that judgment is made on key factors that are codified: limitations in design and execution of studies, the indirectness of the evidence, inconsistency, imprecision, and consideration of publication bias. It's also important for clinicians who are reading a grade document to understand how to interpret the recommendations. There are essentially two types of recommendations: strong recommendations, which start with, we recommend that. These recommendations are based on very strong evidence, and accordingly, most patients would want this evidence used in their care, and clinicians should provide it. However, a lot of the recommendations in the GI literature, especially, and the GI sphere, are conditional, which start as, we suggest that. And that's really a function of the certainty of the evidence. But what implication does that have for the clinician? Well, that means that the patient may or may not want this action. Multidisciplinary discussions are also needed because there's not always a clear-cut answer. And shared decision-making becomes really important in the overall care of the patient. So let's talk about some of the principles of the 2022 guideline as it would apply to operationalization, and more importantly, concepts that every internist should know. When it comes to an antithrombotic acute GI bleed, there is a new and important step, which is that of triage. And I'm not talking about triage to create a situation of hemodynamic stability. I'm talking about triage to decide the next appropriate course of action endoscopically for this patient. So who are we trying to identify? We're trying to rapidly identify the patient with a life-threatening hemorrhage. These are folks who are in your intensive care units in hypovolemic shock, who are often on pressors, and they fulfill what I call the rule of fives. They've experienced a decrease in their hemoglobin of greater than 5 grams or have required transfusion of greater than 5 units of packed cells. These are the patients who are at risk of causing death. Now, why is it important to identify these patients? Well, the treatment of those patients is different and more urgent, and more importantly, when it comes to an anticoagulant GI bleed, these are the patients in whom you should be considering using a reversal agent. All right. The choice of reversal agent is determined by the anticoagulant that's used. Now, the American Society of Gastrointestinal Endoscopy guideline in 2016, which I was also privileged to write, gave you two options: 4-factor prothrombin complex concentrate with factors 2, 7, 9, and 10, as well as vitamin K provided by IV to reverse a supratherapeutic INR in a patient with a warfarin bleed. In 2022, we again endorsed the use of PCC because of its rapid and reliable correction of INR, and we again endorse avoidance of FFP, and that's because of the fact that large volumes of FFP are actually required to modestly decrease in INR, and these products are associated with a high risk of transfusion-associated complications such as pulmonary edema, as well as infection risk. So we again endorse that, but what's different about this 2022 guideline is we do not endorse the use of vitamin K. And this is going to be a paradigm shift for a lot of physicians who are used to giving vitamin K in this setting in anticipation of endoscopic procedures. And the reason why we changed our guidance on this use is because of the evidence and the fact that we now know that one of the most important things you can do for a patient who's having an active GI bleed is to intervene within 24 hours. And the use of vitamin K does not achieve rapid reversal. So it actually has a limited value in the acute GI bleed setting. When would you be using vitamin K? If the plan is to reverse the anticoagulant effect more slowly for a procedure in 48, 72 hours, then it might be helpful. Or if the objective is to stop the vitamin K antagonist altogether because of the toxic side effects, then vitamin K can be very helpful. But I always caution gastroenterologists against using or recommending vitamin K in this setting without consulting the patient's hematologist or cardiologist. When it comes to the resumption of warfarin after management of the GI bleed, there's a remarkably little in terms of high certainty evidence. As you will recall, we defined all our clinical questions with a PICO format. And so our intervention was the resumption of warfarin on the same day of the procedure versus 1 to 7 days after the procedure. And that PICO question is how and dictated the way the Cochrane collaboration did our literature search. And even though warfarin's been around for almost 100 years and has been a major cause of GI bleeding, we have very limited high certainty evidence in both the acute as well as the elective setting when it comes to endoscopy to inform drug resumption. So I always remind people that there is no tug of war between the heart and the GI tract. the heart always wins. And so you really have to be paying attention to the balance of risk versus further risk of bleeding. But what we know from the cardiac literature is that if you resume the warfarin within 4 to 7 days of drug discontinuation in the setting of procedures, the patient has less than a 1% embolic risk in the setting of endoscopy. All right, so I think we often over-predict the risk of embolic consequences, and that can lead to an unnecessary amount of premature resumption of drug, or we over anticipate the risk of post-procedural bleeding, which leads to an excessive amount of temporary interruption. When it comes to the new direct oral anticoagulant agents, it's really important that you understand that you should not be reversing every patient. Reversal agents are best reversed for those patients who meet that definition of a life-threatening GI bleed. And that's because of the thromboembolic risk of these drugs, which range from 5% with idarosizumab, which reverses dabigatran, to as high as 10 to 12% with andexanate alpha, which is used to reverse rivaroxaban or apixaban. The other issue here is the cost of these drugs. Andexanate alpha, even at the half dose, which is now recommended for use, costs over $22,000, a cost that is often not paid by Medicare and is then applied to the patient's bill. And idarosizumab, which is still costly, is also not covered by Medicare in many settings. But you should be considering them if the patient has taken that appropriate drug within 24 hours and has a life-threatening hemorrhage. But I want to introduce you to a new option, and that's the role of PCC. That agent I told you was preferred for warfarin bleeding. We now know, based on emerging literature, that PCC can be a bit like the Allen key and is helpful in reversing all anticoagulants, including direct oral anticoagulants. It can be done predictably and often within 2 hours. When it comes to resumption of the direct oral anticoagulant after the GI bleed, we again have absolutely no data in the GI bleed setting. So we have extrapolated the good data we have in the elective setting. And this is also based on the pharmacology of these drugs, which are have very short half-lives and are very quick to act and get to a therapeutic anticoagulant effect. So what is it that I recommend folks do? That you resume the DOAC the day after the procedure in most, providing endoscopic hemostasis has been achieved. And even the cardiology organizations agree that you really shouldn't be holding a DOAC post-procedure for more than 72 hours, because that's an inflection point where the risk of thromboembolism goes up. So for any proceduralist who's even contemplating holding that drug for more than 24 hours, it's really important to have a multidisciplinary discussion so the patient and the team is aware of the patient's risk of thrombosis versus the risk of post-procedural bleeding. One slide on the management of acute antiplatelet GI bleeding to summarize the important things that I want you to take home today. There are still far too many routine platelet transfusions in this population. We now know from good evidence that it doesn't help you, it actually hurts the patient. Many platelets who are provided with a platelet transfusion. There is a soft recommendation to consider it in the severely thrombocytopenic patient, but again, the risk of thrombosis and mortality associated with platelets cannot be overlooked and needs to be discussed in a multidisciplinary fashion. The second thing I'd like you to take note of is that it's not necessary, and in fact not advised, to interrupt cardiac aspirin in the setting of GI bleeding, because of good evidence that shows that it actually reduces mortality to continue the aspirin and then proceed with treatment. Often by the time we see them in GI, the patients have already had their aspirin discontinued at presentation. So we recommend that the gastroenterologist ensure that that patient has that drug resumed very, very quickly. And our latest GI bleeding guidelines recommend within 24 hours of successful endoscopic hemostasis. Now, I would like you to pay attention to the fact that I'm talking about cardiac aspirin use for secondary prevention, not aspirin for primary prevention, which has been now shown and accepted in cardiology circles to have very little cardiovascular benefit with a very high GI bleeding risk. Let's turn our attention to paradigm shifts in the elective endoscopy setting. How do you manage these cardiac patients on these drugs? Well, the prime directive is do no harm and defer elective exams until patients are no longer at high risk of adverse events with temporary interruption of drugs. So who are those patients? Well, they're shown here in this table. They're essentially patients who are less than 3 months out from TIA, stroke, DVT, PE, and acute coronary syndrome. If the patients have had drug-eluting stents in place, up to 6 months is the highest risk period, a bare metal stent up to 4 weeks. And if that patient had stents placed in the setting of acute coronary syndrome, there are specific timeframes there. During those timeframes, we shouldn't be doing elective endoscopy. So we should be deferring our screening exams for both colorectal cancer, Barrett's esophagus, GERD, looking for issues such as sources of pain and anemia. Even cirrhosis screening and surveillance can wait until patients are out of that high-risk period. So let's turn to the patient or the elective management of warfarin. I've shown here the flow diagram in our dissemination tool because there's an important change of practice to highlight. You've done your risk assessment. The patient is not at high or intermediate risk of cardiovascular disease, so you know it's okay to go ahead with this elective procedure. The first thing you need to figure out is this procedure likely to have a high or low risk of GI bleeding after the procedure? And that's a prescriptive formula, and I'll show you that in the next table. But if the patient actually is undergoing a procedure with a low risk of procedural bleeding, which is essentially all the diagnostic GI endoscopic luminal procedures, EGDs, flex SIGs, colonoscopies with biopsies or removal of small polypectomies, ERCPs and EUS without stonework or needle aspiration. These are all low-risk procedures. What's new here is if the patient's been prescribed warfarin, you can continue the warfarin safely and still successfully and safely do these low-risk bleeding procedures in patients on warfarin. Here's that table that I referenced, which you can find in our guideline. And as I've highlighted here, almost all our diagnostic and non-mucosal disrupting procedures are in that low to moderate category. So these are all procedures that can be done safely without stopping warfarin. Why has that paradigm shifted? Well, that's because of data that's been published since the 2016 guideline was created and published, which shows a favorable profile for continuation with very low or no risks of GI procedural bleeding and a non-significant reduction in thromboembolic events. So that's a new thing, which is very much welcomed by our colleagues in cardiology. However, when it comes to advanced procedures, there are just no studies in the advanced endoscopic space that continue these drugs reliably. So we really can't comment on whether or not that would be safe. So our current guidance is for any advanced endoscopic procedure, you should still continue to interrupt the drug warfarin for 5 days without bridging heparin. Why is that important? Well, we now know from very robust data in cardiology that the indiscriminate use of low molecular weight heparin bridging during warfarin interruption increases the risk of post-procedural bleeding without reducing thromboembolic events. We know that from the Bridge and the Peri-Op 2 randomized control trials, as well as 5 very well-conducted observational studies. There is a subset of cardiac patients in whom bridging is required, and those are the folks with mechanical valves. You should consider it in high CHAD score patients, although it is acknowledged by one of our co-authors and the lead investigator of the Bridge trial that patients with high CHAD scores were just not enrolled in the Bridge trial or the Peri-Op 2 randomized control trial. These are also, you should also consider bridging in patients who have had clot events during previous temporary interruption of warfarin, and certainly after some high-risk cardiovascular surgeries. But in everybody else, you don't need to bridge them, and you can still safely stop their warfarin for 5 days in the setting of an advanced procedure, or continue it in the setting of a low-risk endoscopic procedure, and manage the risk-benefit favorably for the patient. Direct oral anticoagulant management has changed since the 2016 guideline, and that's because of a pause study. The pause study was a perioperative assessment of the use of direct oral anticoagulants in all surgical settings, both high and low-risk surgical procedures, following a standardized algorithm. For all endoscopic procedures in this international study, the drug was stopped the day before the procedure and on the day of procedure, with resumption the day after. And what was found was, following that algorithm, there was a very low risk of GI bleeding of only 2.5%, and less than 1% risk of thromboembolism and mortality. Now, this is important data for us in GI, and I was very fortunate to be able to analyze this data with my principal co-author from Canada, my counterpart, Alan Barkin. And it was very reassuring to see that we could simplify our process for managing these drugs in the peri-procedural setting with very good clinical outcomes, because previously we used to have to adjust the timing of temporary interruption based on the patient's kidney function, their creatinine clearance. You don't need to do that anymore. This is all you need to do. This is the recipe. For all low-risk GI endoscopic procedures, you're going to be holding the DOAC for 2 days. For high-risk procedures, you're going to be holding the drug for 3 days, including the day of procedure. And in most patients, you're going to be resuming the drug the day after the procedure. Again, because of the short action and short onset to activity, and more importantly, the short half-life of these drugs, the American College of Cardiology and the American College of Gastroenterology do not recommend holding DOACs post-endoscopic procedures for more than 48 to 72 hours without having a multidisciplinary discussion. Nothing has changed in the elective management of dual antiplatelet therapy management. Before endoscopy, you should still continue the aspirin for any endoscopic procedure while temporarily interrupting the phenylpyridine or the P2Y12 inhibitor. It's important to understand that that period of temporary interruption differs based on agent. For clopidogrel and ticagrelor, it's only 5 days, whereas prasugrel, based on its pharmacology, requires a longer period of temporary interruption of 7 days. We now have very good evidence in the GI literature that it's actually to the patient's advantage to have temporary interruption of their phenylpyridine while continuing aspirin with regard to post-procedural bleeding and cardiothrombotic events. This comes from 2 randomized controlled trials in the GI literature, as well as a systematic review of cardiac studies in low-risk surgical procedures that was published by Eisenberg. When it comes to resumption of these phenylpyridine agents, again, we could not reach a recommendation because we could not find any studies that met the definition of our PICO question. which was resume on the same day of the procedure versus 1 to 7 days after the procedure. But what I found really interesting when we reviewed our studies, which were over 5,000, the abstracts and studies that were sent to us by the Cochrane collaboration, you would think that earlier resumption would reduce the cardiac adverse events and increase post-procedural bleeding. But we actually could find no studies that actually pointed to that fact. So our current recommendation is to resume dual antiplatelet therapy with immediate endoscopic hemostasis. So I'm going to end here today with some important take-home points that will help you frame the way you're dealing with these patients. When it comes to an acute anticoagulant GI bleed, the first step is to triage the patient based on life-threatening hemorrhage versus not. The importance of that triage step is to determine in whom you should be considering a reversal agent. Reversal agents should not be used in everybody. If the patient's having a warfarin-related life-threatening hemorrhage, we want you to choose PCC. You do not want to be using FFP or vitamin K. When it comes to a DOAC life-threatening GI bleed, you can consider a DOAC-specific reversal agent if the drug has been taken within 24 hours, or optimally PCC, which is equally effective and much cheaper. When it comes to an antiplatelet GI bleed, you really must stop giving patients routine platelet transfusion because in the setting of GI bleed, it increases the risk of mortality 5-fold. And remember, you should always continue the aspirin, cardiac aspirin prescribed for secondary prevention in the setting of GI bleed because it does confer a mortality benefit. In the elective setting, defer elective endoscopic procedures until patients are out of those high-risk periods. And if for any reason you cannot defer an elective procedure, shared decision-making, multidisciplinary decision-making should always guide your choices. When it comes to elective procedures with warfarin management, you can now continue the warfarin if the endoscopic procedure has a low risk of bleeding, but you still continue to hold the drug for 5 days for advanced procedures, resuming with immediate hemostasis. Bridge anticoagulation should really not be in your regular lexicon of use except for a very select group of patients, and certainly never in patients who are prescribed DOACs. The management of direct oral anticoagulants in the peri-endoscopic elective period has become formulaic. In most patients, you'll be interrupting the drug for 2 days, including procedure day, with resumption the day after. And for advanced procedures, 3 days of interruption, including procedure day, with resumption the day after. When it comes to dual antiplatelet therapy management, it's the same story. You continue the aspirin for endoscopy, but you do hold the phenylpyridine agent for a prescribed amount of time based on the agent. And as always, you resume the regimen with immediate hemostasis. Let me conclude by sharing some of my own musings about establishing best practice after having participated in 8 best practice document creation processes for 5 different national organizations and 2 international organizations. The importance of having a grade process is because it helps create a structured approach to literature review and really helps ascertain the quality of the evidence that contributes to our recommendations. But I acknowledge that this is a very time-consuming process. And it also is limited by the number of physicians who are trained in this very rigid process. And because of the limitations on that training for proper grade methodologists, this limits the practicality of it. Practicality is also limited by the inherently academic nature of a rigorously done grade document. The bottom line is people read that document and read our 22 document and say, I just don't know how to use this document, which is why the grade organizations, as well as most national organizations that endorse grade methodology, also recommend the publication of a companion dissemination tool, which is really the practical nuts and bolts of how to use the document and how to implement recommendations in real life. The other thing that's really important about the grade process versus all other processes is it really helps distinguish between opinion and fact, and it gives a prescribed way of dealing with conflict of interest and resolving that conflict of interest among members of the panel. I've certainly been in many rooms where the loudest voice wins, and often that loudest voice does have a conflict of interest. So grade just introduces transparency, not just in terms of literature distillation, but also in terms of literature interpretation. But all of these processes today, grade versus non-grade, often miss the most important voice, and that's the voice of the patients. And there are some subspecialties in medicine that are now moving towards including patient voices in the creation of their best practice documentations and recommendations. And I think that's actually an important step forward. So I've shared a lot of information with you today. I hope I leave you a better informed consumer of best practice recommendations, knowing how to interpret data based on the rigor of its development and presentation. And I hope I've also shared with you some key considerations in terms of the contemporary management of antithrombotic drugs in this patient population. Thank you very much.
Thank you, Dr. Abraham. I'll be taking questions via the chat, but as we're waiting for people to file in with questions, maybe I'll go ahead and ask one that's sort of a non-GI person. Is there one of the newer anticoagulant agents that is really problematic from a GI bleed standpoint? In other words, is one of them more associated? Is one versus another more associated with severe life-threatening bleeding or hard to control bleeding compared to the others?
Absolutely. There's absolutely no contest when it comes to that story. Xarelto is the worst direct oral anticoagulant and has the worst GI bleeding profile. Apixaban is the safest. You can reduce a patient's risk of GI bleed by 64% by just switching the patient from Xarelto to apixaban. You can further reduce the risk of GI bleeding by ensuring that that patient on chronic anticoagulation has been prescribed a proton pump inhibitor, and most importantly, knows how to take the drug correctly. You must tell them to take it 30 to 60 minutes before eating to optimize the effect. That combination can virtually eliminate the risks of GI bleeding to a negligible level as long as the patient's not over the age of 75. That's a risk factor that is unfortunately unmutable. I wish I could find a way to decrease that risk.
And just a follow-up to that question, is there any antiplatelet agent that's worse than the others or more highly associated with bleeding events than just conventional low-dose aspirin?
Yeah, with that question, the answer is a little less clear. My group has studied this as well as some other groups, and we all come up with different answers. The one consistency is Plavix is middle of the road. There is some debate based on studies whether or not prasugrel and ticagrelor are better or worse. In the large study we did at Mayo, we found, and we looked at over 100,000 patients, ticagrelor actually had the highest risk of GI bleeding. Clopidogrel was middle of the road and equivalent with aspirin, and prasugrel was the lowest. But again, that differs based on the population source that's used to do those studies. So I don't think we have a clear answer there yet. But what we do know, sorry to jump in here, is that those patients also should be on chronic PPI therapy, which has been shown in both RCTs and GI and cardiology to reduce the risk of GI bleeding with chronic antiplatelet therapy.
Okay, thank you. There is one question in the chat that came up, and it's not directly related to GI or GI bleeding risk and anticoagulants and antiplatelet agents. But there's a question: Do you accept residents at your program, Dr. Abraham?
Well, we have a very robust GI fellowship program, which we are always accepting fellows into. And you can be assured that all my fellows graduate from my program having been indoctrinated in the way of cardio GI, because many of them work with me. But if you're asking specifically, do we have a fellowship in cardio GI? We do not.
Thanks. Other questions or comments from the audience? The person who asked that question said thanks. So,
Conrad, another question is here. How do we ensure new guidelines reach all levels of training most expeditiously? Things are changing and changing often sometimes, and many are not aware of the new updates.
Yeah, that's a real problem. Yeah, that's a real problem. There has been literature on this, that it takes up to 15 to 20 years in some subspecialties for a guideline to hit the rank and file in the community and most patients. And as all of us know, by that time, often recommendations change. So it always feels like a lot of our clinicians are at least one chapter behind. From the perspective of the American College of Gastroenterology, we've taken a very proactive stance on this count. We do a lot of communication related to guidelines, both in print, by podcasts, electronically, virtually, lectures. You cannot go to a GI meeting that's not a liver-related meeting in the United States without seeing a lecture or two on this topic done by me. So there's always an opportunity to upskill. And finally, for the first time last year at the annual meeting, we have a new living book called The Guide to the Guidelines, created and authored by the two gastroenterologists who've created the series Acing the Boards, which is, is known to have epic fame in GI circles. That same group has created a book for the ACG called The Guide to the Guidelines, and they're covering not just the ACG guidelines, but all GI and hepatology guidelines. And that's a living document, and that will be published iteratively. So as guidelines are updated, they will have summarized the key clinical pearls in their own distinct, pithy fashion. And I encourage all gastroenterologists to subscribe to that book, because that will help keep you up to date.
Dr. Abraham, a question came in from Dr. Young. And that question is, how do we ensure that guidelines are not used to deny care by insurers?
Yeah, I get asked that question a lot because I've written so many of these, and I always remind lawyers that a guideline is a best practice recommendation. It is not the law, because each patient is individualized. And certainly in my own practice, I see a lot of patients who are at extraordinarily high risk of thromboembolism. And there are factors that can predict that. And so we don't want to be stopping or interrupting drugs. So we make different decisions. That's why in our guideline in particular, we stress with almost every recommendation two things. This will work for the most, but there will be some patients in whom an individualized decision is necessary. And in that situation, you need to have a multidisciplinary conversation.
And from my perspective, I appreciate your comments about implicit biases or potential biases from individuals who might be on these panels, who make guidelines. I'm in the field of infectious diseases clinically, and I think a lot of the ID guidelines have a lot of potential conflicts of interest involved in their preparation, because generally the people who are on those guidelines are the ones who have the most experience with what such and such drug, and that's already a problem. But I don't know how to get away from it either.
Well, I think it's important that all fields move away from that, because the grade mafia, as I fondly call them, is international, right? And they have started publishing in very big journals systematic reviews of society guidelines in the United States and elsewhere that really do fail on all those counts in terms of evaluation of the literature, dealing with conflict of interest and resolving those conflicts, and the introduction of bias. And they don't mince words. There was an Annals of Internal Medicine paper a few years ago from this group that absolutely skewered the nephrologists. So we went into our guideline process hoping never to be on that list, which is why we follow such a rigorous grade approach.
Yep, yep. Other questions or comments?
There's another one.
Another one came up. Okay, sorry. Go ahead.
Okay. When guidelines are massive reviews, and then in parentheses, as they often are in cardiology, they're actually hard to use.
Yeah.
Do yours include simple to use visual abstracts? And what is the best format for dissemination?
Yeah, that's a great question, and something we wrestle with at the leadership level of the American College of Gastroenterology all the time, which is why our guide to the guidelines, which is almost a comedy hour, but edutainment, as I like to call it, is we think going to be very effective. Yeah, those systematic reviews or the narrative review format of best practice recommendations are the absolute worst, full of bias and opinion as opposed to evidence. And they are also very difficult to translate into easy to disseminate tools. If you look at our dissemination tool that accompanies our guideline, we use a lot of flow diagrams, we use a lot of care pathway type language and pictograms, as well as tables, things that are easy to print out and put in your endoscopy suite. And actually, the American College of Gastroenterology has lovely versions of that you can actually do if you want them all laminated and in a nice bunch. But it is hard. Dissemination, I don't think any society has figured out the secret to widespread dissemination and uptake. I think that's still a problem.
Yeah, and Bruce Posady asked that question. He has an interest, in cardiology type guidelines. And I'll say, Bruce, it's just not a cardiology issue. It's an issue in other fields too. Say like there's a guideline, for ventilator associated pneumonia. It's 300 or 400 pages. It's absolutely useless. And anyway, it's a problem. And Dr. Abraham, you mentioned, the Canadian side of things. When I was in Canada, they had me, of all people, because I'm not really a guideline preparation sort of person at all in terms of my research, but they had me on doing guidelines to add a little bit of dissent at times, into the ID world. And that was one of my biggest gripes was these guidelines are just too long. They're not really guiding anybody in terms of clinical practice. You've got to reduce everything down to one page, and so somebody can digest it. And I made that a requirement for the Canadian guidelines, at least in ID.
Yeah, and the Canadians are actually the ones who have really championed the grade recommendation to create dissemination tools.
Yep.
And that's our guideline in 2022 was the first dissemination tool that accompanied any American guideline. And now you cannot publish an American College of Gastroenterology guideline without an accompanying dissemination tool. So we have shifted the practice here.
Yeah, the Canadians have a term for that. They call it KT, as you probably know, knowledge translation, right? That term never got used very much or never made its way south of the border, because I've never heard anybody in the States call things KT, and that was a part of every grant in Canada, is that you had to have a KT section of how your findings could be, expanded to clinical practice potentially. So KT was a very big, or knowledge translation was a very big component of research up in Canada. Any other questions that you see, Ratanya?
I do not.
If not, thank you very much, Dr. Abraham. That was a nice review of bleeding complications in GI and what to do about them. So thanks a lot for your presentation. And congratulations on being the Volwiler visiting professor for 2024. Thank you.
Thank you very much.
Thanks so much, Neena.
All right. Let's see.